Okay, everyone, thanks for joining the Baltimore County Fire Department EMS series. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and an ICU physician at Hopkins. I am a active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving as Associate Medical Director in the EMS office for Baltimore County. On behalf of the Medical Director's Office, thank you for being here. On behalf of the EMS Office, Director Shenning, Captain Stewart, who is with us tonight, Captain Willits and Captain Knotts, thank you for what you do. Thank you for your dedication to lifelong learning. A couple of rules or thoughts about the platform in terms of Zoom. I hope everyone can see the chat function on the right-hand panel. I think you should be able to see that. If not, up at the top, you can do also speaker view or kind of a matrix view. I personally like speaker view. It allows whoever's speaking to be the predominant screen that you see. Down at the bottom, you can see controls to mute yourself. I do ask that everyone now practice to mute yourself so we have a quiet background and we don't hear background noise. So please exercise that. This is a little test to make sure you're with me, Beth, and others who I see who haven't quite muted yet. In addition, I would ask him when Frankie starts his talk, I think it's good etiquette to stop your video. Stop your video. That is on the bottom as well. I find that videos are very distracting. I invite you to turn on your video towards the end when we have question and answers if you have a question. I also invite you to keep an eye on the chat function on the right-hand side of the panel as well. That's a way you can communicate with me directly as your host, or you can communicate with everyone if you have questions. Towards the end, we'll definitely have an open and answer as well, where you are welcome to unmute yourself, turn on your video, and ask Frankie a question one-on-one. Still admitting a couple of people. Also, I'll do a quick shout out as well to Ashley Brooks and Hunter Darden, who are young people, volunteers at Pikesville, who are online. They're gonna help us monitor the chat function. They're also gonna be sending out via chat a link to a document if you want CEUs and you're an individual or a volunteer company joining as a group, please keep an eye out on that link on the chat to allow you to make sure that you get information to do your CEUs. If you're a career station with a group of people, please coordinate your efforts with Captain Stewart to get your name in so we can get you CEUs for this. Yeah, I think that's about it. I'll just pause for 1 second. If anyone has any questions, feel free to unmute and ask or send me a quick chat. Any concerns? Everyone here? Everyone's doing well. So let's practice turning off your video, please. And for those who join late, please practice muting yourself as well. Making progress. Great. Okay, so thanks so much. So tonight we have Frankie Catalfumo. Frankie is an infection control epidemiologist with Johns Hopkins Hospital. His focus during the response to COVID has been to support the Johns Hopkins Health System develop and implement infection prevention and control practices to ensure staff and patient safety. As a frontline provider at Hopkins for the past 24 years, and now during this COVID event, Frankie, I thank you. I thank you for all the work that you're doing to support us. I'm getting all choked up. Thank you for helping us make sure that we're safe and for what you've already said. And I know how much you appreciate the first responders and for that being so generous to share your wisdom and to answer questions to make sure they as well feel as safe as they can. Thank you so much.
Absolutely. It's a pleasure being here. I was a first responder when I was in college. During college, I was an EMT on an ambulance, and I also worked in an ED as well at a hospital prior to entering public health, where I started becoming an epidemiologist that studies the spread of disease. And since then, I've transitioned to hospitals overall. So today I've got a few questions. So we will be hitting on a lot. So I'm just gonna go ahead and give you a general spiel about COVID and then hit on a few of the points that the questions have warranted. And then at the end of this, we'll go ahead and go into a Q&A. So it's been a long time that we have been hearing a lot of information about COVID, and it's the first pandemic a lot of us have seen. So this is a stressful event, and it's stressful for anybody in the healthcare industry, especially our first responders and people on the front lines, because we're encountering those people who are unwell, who may have it, and it's unknown until they get tested. So just a general overview about COVID. COVID is a respiratory illness. So respiratory means it's affecting your lungs, and it is a virus spread primarily by large droplet nuclei or any aerosol. So what I mean by large droplet nuclei is if I sneeze or cough, they're rather large droplets, and it can go up to 6 feet. And this is where the physical distancing of 6 feet comes in. It creates a safe zone for you for the sneezing and coughing. This goes for any respiratory virus, more commonly flu as well. So we have the large droplet nuclei, and then we have potential aerosols that go in the air, so small little fine particles. And that can happen during any aerosolizing medical procedures, nebulizers, suction, so on and so forth. So COVID is a novel coronavirus. It's a novel respiratory virus. So the symptoms can range from mild to severe, and overall, because this is our first time encountering it, this novel virus, it's brand new, so there's a lot of unknowns to it. So as we learn through the research published, we find out more information to adapt our guidance. And adapting the guidance is always the tough part, because we change little things here and there, and we have to push it down to our front line. So getting to how COVID spreads in general. So we know that I talked about that physical distancing 6 feet. And additionally, we have other types of practices to limit that spread. The best thing to do is honestly hand hygiene, because this is where we're actually coming into contact with a lot of high touch surfaces. So generally speaking, in your ambulance and in your firehouse and stuff like that, you may be cleaning more often, but you can think there's probably other high touch surfaces just in your general community, like doorknobs, car handles, and things like that that don't get cleaned as often. So your fingers, your hands are actually culprits. And the danger too is when you touch a mucous membrane. So your mucous membranes would be your eyes, nose, and mouth. So this is a very big one overall. You can't get COVID if you don't give it an entryway. So virus is inherently dead when it is on a surface. It needs a host, a human, to go ahead and incubate to actually replicate. So as long as you're not touching a surface and then touching your eyes, nose, or mouth, your mucous membranes, you're not giving it an entryway. So this is why we mean by good hand hygiene will keep you very safe. That's one of the best practices. The thing is, we don't think about it a lot. So on average, a human may touch their face up to 46 times an hour, which is a lot. And now, because of universal masking, sometimes at the grocery store and other places as well, you may be adjusting that a lot more and then touching your face. So this is something to be conscious about overall. So I want to go ahead and dive into some of the questions that we got. So what are the odds of catching this if I had a patient and I have PPE on? So PPE is your personal protective equipment, and generally per CDC guidance, which is the benchmark for how we approach everything, is suggesting airborne PPE, so a respirator with eye protection along with some droplet precautions as well, which would be a gown and gloves. So if you are in your full recommended PPE per CDC guidance, then you are at no risk as long as there's no breaches in your PPE. I will be sending a link that has a nice table of how to assess your risk overall. And ultimately, your risk would be low. We don't say no risk because no risk is not quantifiable, so we would say low. If you are in your full PPE and there's no breaches, it's very low risk when you encounter a suspect, patient under investigation, or a confirmed COVID positive patient. So ultimately, you have tiers when it comes to PPE overall, and it's based on whether or not you think that this person may be a suspect COVID case or a confirmed COVID case. So say if you didn't have your goggles on your eye protection, then your eye protection would be a medium exposure risk overall, because your eyes are a mucous membrane and this person may have cough, which means that it's coming out of their mouth, then this would be a medium risk. And this is per the CDC guidance. I don't know about the practices that are practiced on the ambulance or other places, but generally speaking, if you can mask your patients to contain any of their infectious secretions coming from their mouth or their nose, that always brings your risk down to low. So that's something that if you do that, if you can do that per your policies and protocols, that might help reduce your exposure overall. So we do have that, and I will send. So what about gowns in general? Gowns, if you are wearing your eye protection, your respirator, you're covering a lot of your mucous membrane. Your gowns, overall, we may be worried about them becoming contaminated in general. But speaking about clothing, the virus doesn't live well on non-shiny, hard surfaces. So if you think about a drop of water on a metal table, it would take a very long time for that drop of water to actually go ahead and dry up. It would stay for a couple of hours, maybe even a couple of days. But if you were to take a drop of water and put it on your fabric clothes, it would go ahead and absorb instantly. So we really don't have a lot of concern for an infection risk from your clothing overall, because the virus can't live well on it. So clothing would be a low risk ultimately. If you do have any breaches in your PPE, say your respirator, that you didn't check your seal and then it was a little bit leaking, or your eye protection came off midway during your medical assessment or during the transport, those would have to be assessed by a case-by-case basis, depending on whatever is happening. So go ahead and consult your safety officer or your medical officer there at your station to go ahead and assess you. Generally speaking, because you're not only encountering COVID during your patient interactions, you may also encounter it with your coworkers and also in the community when you're going to the grocery store, so on and so forth. I highly recommend everybody to always check their symptoms. So the most common symptoms that we are seeing, go ahead and check yourself daily for these symptoms, just so you can understand whether or not you picked it up. But good best practices such as hand hygiene, so on and so forth, can reduce the opportunities for you to get it. But the most common symptoms are fever. So we have a fever that could be low grade, but generally we're looking for about a little over 100 would be a fever. We would have a sore throat, shortness of breath, and then a new symptom that they've socialized is a decreased smell and decreased taste. So these are some of the more common symptoms that we are seeing. So if you notice them and they're not your baseline whatsoever, meaning that you haven't had them, they're brand new to you, then go ahead and consult one of the medical officers in your station just to run it by them overall and to get an opinion about that. So those are the symptoms that you're looking for. So moving on to the next one. Next question, if I was in a hospital with a patient, is my family at risk? There is a low risk if you are in the hospital with a patient overall. And the best part about healthcare is if you have access to your PPE, you're reducing your risk very greatly. So if you're encountering somebody, they would be under the appropriate isolation, or you should be taking that under consideration during your medical assessment to don the appropriate PPE that you need to protect yourself. So you would actually have to contract the virus and become infected with it to put your family at risk. And then that's where I say you really need to monitor your symptoms, because you're encountering so many people as first responders. You need to continually check yourself to be like, is this my baseline? Is it not my baseline? What can I do? So that's something to keep in mind, is monitor your symptoms. You can't put your family at risk if you're not infected. When you are infected, that's when you're putting your family at risk. Generally speaking, you're most infectious when you do have a fever and symptoms. We do have a pre-symptomatic phase that maybe a lot of people are hearing about in the media, saying there's asymptomatic transmission or there's pre-symptomatic transmission. typically, if people are in this category that are asymptomatic or pre-symptomatic is what I say, because we always have an incubation period for a virus to pretty much take a root in the host and start replicating, and then a manifestation of symptoms. They're not as infectious during this asymptomatic or pre-symptomatic phase. Yes, they will likely be shedding virus, but it's not going to be as infectious as if they have a fever. And then that's why I tell people to monitor their symptoms, saying if you don't feel quite right, then go ahead and make sure that you're taking the appropriate precautions to protect yourself and then the loved ones that you're sharing a household with, and then also your coworkers, because in a firehouse and in an ambulance, these are very close quarters as well. Can I get this from my hair or should I shower between calls? So generally speaking, this is a respiratory virus that likes respiratory receptors in my lungs. So it's going to primarily be attracted to that in my lungs overall. So can I get it from my hair? No. Ultimately, a hair is not even a good fomite for the virus to stick and live. As I mentioned earlier, it prefers shiny metal surfaces that it can't dry off of too well. So hair is not really a concern. Should you shower between calls? I think generally a best practice always, because you're encountering a variety of things, is go ahead and shower maybe after your shift or when you get home, change and go ahead and shower. I think that this is a best practice just to have in general. I can't exactly comment on the infection risk or if there's an infection risk, but we do know there's other hardier organisms out there that can last for a long time. For example, Clostridium difficile, C. diff, is a hardy spore that can last for up to 6 months in the environment. So that can be tracked around. So generally as a best practice, if you would like to go ahead and shower after your shift and after you have had all your patient interactions for the day, and if it makes you feel better, because I know it made me feel better when I was in EMT, then go ahead and do so. The same thing for your shoes. Shoes are a big one that we hear about, is what should I do with my shoes in general. I think a best practice is always kicking them off in the same place, maybe keeping them in a bag in your car or just keeping them in your trunk. Your shoes are not at a risk to you ultimately, because you're not taking your shoes and you're not licking them, as I tell people in the hospital. You're not rubbing them on any mucous membrane. So effectively, there's a very low risk if you're not picking up your shoe, manipulating it, touching it a lot, because that's what I'm worried about, is people touching things and then touching their eyes, their nose, their mouth. And then this is where people are trying to think about their shoes and what kind of risk they have. Ultimately, we do encounter a lot of situations on the fire truck and on the ambulance in particular, where it's not exactly clean, or we don't know where we're going, or we're entering somebody's home. So putting them in the same place and then kicking them off before you walk in your home is a best practice. It also reduces the odds of you picking them up more often. So what about clothes? Do I need to have a station professionally disinfected? No, as mentioned, clothes are not a good fomite, is what we say in epidemiology. So fomite would be it can transfer the virus to another thing. So because they can't live well on fabric surfaces, I'm not really worried about clothes. As I said, if it makes you feel better, so there's like a psychological safety almost into it. If it makes you feel better, then go ahead and change at the end of your shift, shower after any sort of patient interactions at the end of your shift, and that will make you feel better ultimately going home to your house with your loved ones or going back to the fire station where there's close settings. If I had a coworker at the station, so ultimately, if you have a coworker at a station who may come down with COVID and you have a loved one that is immunocompromised, ultimately this goes back to you will encounter this virus in multiple settings overall, from work to potential scenes that you're a first responder to your grocery store. And ultimately, it's about taking the great practices that you know to keep yourself safe with the hand hygiene, with the physical distancing if possible. And you cannot pass on the virus if you're not sick. And monitoring your symptoms would definitely help that for any individuals. And if you do live with people that are immunocompromised, then I would recommend you come up with a plan to go ahead and have an idea in mind. What would happen if you are sick? Do you have the infrastructure in your home to at least separate and isolate away from them if you were to come back sick with COVID, because it is circulating widely? So as soon as you have that plan in place, it can help you be more prepared for the future, and it will lower your anxiety. When we plan, as we know from drills and exercises using emergency management, that they help us be more prepared to identify any gaps in our systems, protocols, processes. So if you do come up sick if you do end up getting infected with COVID, you have a plan in place, or if you at least have a few steps in place that ultimately will help keep your loved ones safe away from you, especially if they're immunocompromised. And something that I want to emphasize with the individuals that are immunocompromised is they're not at greater risk of catching the virus. They're at greater risk of a more difficult time battling the virus. So the example that I commonly give is, if I have asthma, then my body's already working very hard on this one thing. So my body's working hard with asthma, generally harder to breathe. So if I have another thing, so I acquire a new infection, let's say it's COVID, because that's the topic of interest right now, then my body is working 2 times as hard to deal with something. So when you have any of these underlying conditions, diabetes, COPD, asthma, I think those are pretty much the big ones that I hear a lot about. It doesn't mean that it's more easy for you to get the disease and contract the virus to get infected. It's harder for your body to battle it. So if you were to get infected, you would probably show different signs or more intense signs as well. And that's knowing what your baseline is about, like, maybe I do have a cough at baseline. I've always had it. I have COPD. My cough is hurting a little bit more. I'm getting chest pain. I have a low-grade fever. It's about knowing those things that if you do, you can identify it early and you can detect it early to start getting the care that you need. So if you have kids okay. I have a question about if you have kids at home and a paramedic on shift was positive. So generally speaking, you can't get COVID when you actually just pass somebody. We need to have some sort of exposure. So per CDC, the guidance of exposure is longer than 3 minutes. And then that's when you're mostly doing some kind of healthcare thing, because that's when you're most likely to encounter somebody who's symptomatic. And when you're symptomatic, if you're coughing or anything like that, that's the large droplet nuclei that are going to come out of your mouth. And those are the infectious secretions that we're worried about. But if you're merely just passing somebody, you can't get COVID during that. We would need some face-to-face interactions, or if they were coughing, you to touch the surfaces and to touch your eyes, your nose, your mouth, to give the virus an opportunity to enter you, to start incubating and to infect you ultimately. So when we think about passing people in general, it's very hard for us to go ahead and physical distance, but it's actually good for us to get in the habit, especially now when we're still seeing a lot of cases in Maryland. We haven't exactly flattened the curve. It's not only in Maryland, it's around the globe in other states, and people are traveling right now as well between states, especially New York. People are coming and driving on down, and people are doing quarantine in different states. Go ahead and practice that physical distancing. Get used to it when you can, especially in the firehouse. I know it's very hard because there's a community there, you have your environment, but getting into the rhythm of that physical distancing is one measure for you to help flatten the curve. It's layers of protection. So that's the way I always say we have layers of protection. So hand hygiene is a layer. Physical distancing is a layer. Universal masking when you're going out is a layer. Universal masking in general is myself protecting everyone. It's not me being protected from you. So what I will mean by that is the universal masking is it's catching all of my secretions that may be infectious. So it's collecting any of my coughs or my sneezes, and it's catching them from leaving. So ultimately, when you do have a mask on, it's catching them from leaving. So it's catching them from leaping out for those 6 feet, which is why the physical distancing is another protective layer. These cloth masks that some people may see are not impermeable. They will catch a good bit. I think some research says 30 to 40% effective at catching any of the infectious secretions, which is a great number ultimately to help us flatten the curve, better than nothing. And these are things that we can go ahead and do over time to help flatten the curve. So there are some questions that if somebody does come out positive, why are we not hearing from any of our management about this? Per HIPAA, we still can't tell if anybody is positive for COVID. So if you do see somebody that you saw the day before and now they are absent, or if they're gone for a few days, try to go ahead and understand that we're in a situation where we would want to respect everybody's medical records. And if they decide to open up to you, they absolutely can, but they do not have to. That's the benefit of HIPAA. So HIPAA still applies here even in a pandemic. So if you were on the same call as a medic who was sick 24 to 48 hours ago, this question is a little bit ambiguous, but I'm going to go ahead and clarify it in my own way, and then I can take some Q&A at the end. So if you were in contact with somebody maybe a day or two before they tested positive, what kind of risk is there ultimately? So then again, we don't know whether or not, and this is a case-by-case basis, but generally speaking, if they are pre-symptomatic, then they're not as infectious as if they are symptomatic. And hopefully when you are with your coworkers or your loved ones or people like that, if you notice something is different, ask them about their cough. Ask them if they're not feeling well, like, hey, is everything okay? Advocate for yourself, because you advocating for yourself is also advocating for your colleagues around. Nobody means to get sick, it happens though. So advocating for yourself to be like, hey, is that cough normal for you? Or hey, are you feeling okay? I'm not sure if you look that well. Just doing general safety checks to ensure that everybody is safe is very helpful. And you potentially can be exposed to that person during the pre-symptomatic phase, but as long as you're taking care of things such as hand hygiene and also wiping down any high-touch surfaces in shared areas, so a lot of doorknobs, door handles, keyboards, knobs, refrigerator handles, so anything that people are touching a lot will help reduce it from spreading around. So I highly recommend even implementing a more routine cleaning schedule within the firehouse or high-touch surfaces. So you can just Google high-touch surfaces online to probably find something to start getting you thinking about what I should clean more often. But I think if you were to walk around the room and be like, what would I touch? Things would come to light overall. Once again, it lives best on shiny metal surfaces. It can live on other things, but fabric, it doesn't live on that long. But generally speaking, the knobs, the handles, things people are typically touching a lot and may not be washing their hands when they interact with. But definitely not touching your mucous membranes, your eye, nose, mouth, or not eating with dirty hands is a big one. Also, cleaning your phones is a really big one as well. So these things go everywhere with us. And I want to say that I've seen people put them in Ziploc bags sometimes on shifts when they're doing things, but that doesn't mitigate it too well. Yes, you're just putting it in a bag and you're protecting it from its environment, but why don't you go ahead and give it a clean? So go ahead and take some 70% isopropanol alcohol, so the rubbing alcohol that you can get at a drugstore, most likely in a medical kit. You will have the alcohol little squares that you can go ahead and clean your phone off. It's the best practice to go ahead and clean it off at the end of your shift as well. You're encountering a lot of things, And when you think about it, it goes everywhere with us. Even in your bed, you'll get with it, and you're on your phone. It's something that could easily go ahead and carry a lot with it. I don't know if it would carry this respiratory virus because there's nothing shiny and metal on it, but ultimately it may be carrying stuff that you don't want. Because this is a novel virus, doesn't mean that we need novel practices to go ahead and mitigate it ultimately. We do have a lot of best practices that we've learned from other respiratory viruses. Yes, there are many unknowns, such as incubation period, how long it stays in the air, pre-symptomatic individuals, but we do have other practices that can help mitigate it from keeping it to spread. So can I talk a little bit about food? How safe is it to get takeout, eat from the grocery store in general? So generally with food, something that we're steering away from is any sort of communal food, which is a big one for a firehouse, I do realize. So in general, it's a best practice not to cook when you are sick, and that's a recommendation in general. So if you are the designated individual for cooking, making sure that you have good hygienic practices. So the best practice that we can always recommend is 20 seconds of cleaning these, and 20 seconds is a very long time. People just typically get in, and the reason why we recommend 20 seconds is it takes that long to get into everything on your actual hands. So when your hands are effectively clean and you have clean surfaces around, you're reducing the opportunity to catch something and then put it in the food. I believe if I probably looked into the research, the virus doesn't live past a heating point of 160 degrees. So, which a lot of times you would cook red meat at least to 155 degrees. So you would be degrading a large portion of the virus. So you're reducing the opportunity if you did contaminate the food ultimately. So I think food is pretty low risk overall, especially if you're practicing good hygienic practices. 20 seconds is a very long time. It's 2 happy birthday songs. And generally speaking, if you're cooking the food like that, generally meat is cooked to about at least 155, then it's safe. As far as fruit at the grocery store, washing with general water. So fruit with the grocery store, if you want to give it a little friction of some sort, go ahead and do that. I don't know any of the evidence-based research out there for fruit, so I can't comment any further. Everything in infection control is evidence-based. It's rooted in some sort of science. I would have to look into fruit in general. But if you're a little bit worried about it, I would have to say steer clear from it. I just don't have that information right now. And one of the last questions before I dive into the chat is, how do I know if I'm an asymptomatic carrier? So we don't have carriers of this. When you're a carrier, it would actually be something genetic that you would carry, but this is an actual virus. So you would be infected with it. This goes back to monitoring your symptoms to understand what is baseline, what's abnormal for me overall. So monitoring your symptoms and then practicing. Another best practice that I would have to say is, in addition to kicking off your shoes, going a little bit backwards, but kicking off your shoes, maybe showering after a shift or patient care, and changing into your clothes is wash your hands as soon as you get in the house. The less opportunities you have to take whatever you touched from the community into your house is a good practice in general. So I'm going to go ahead and read some of the comments, and then we can dive into a Q&A. Can N95 masks or other safety equipment be sanitized with UV light? So there's a lot of research out there and conflicting viewpoints for sanitizing or disinfecting your N95 mask ultimately. So per Hopkins and the research that I have read, we're not really worried about getting any of the particulate that it has filtered. Your N95 has filtered. We're not worried about that re-aerosolizing. So for example, I think some of the research that I said is you would actually, even if you were to bang your N95 against a hard surface, but because it actually has a positive static charge to it, which bonds to the particulate, you're not really going to aerosolize anything. I think that this may be something that the hospitals are doing for a psychological safety, meaning it's making the staff feel better. Ultimately, N95s are still good, especially in a pandemic. We relax a little bit. N95s are still good if they're not soiled, wet, or damaged. And the reason why this most frequently happens is you have face oils, you have makeup, you have lipstick, you have facial creams that may go ahead and saturate it, especially if you're in a lot of equipment and gear. If you go ahead and you're wearing your N95 respirator, you may saturate that a little bit more. Per the instructions for use of various manufacturers, it's really good that if you're not wearing your N95, to store it in a paper bag. And the reason for that is the paper bag will help wick away the moisture from the actual N95. So we currently at Hopkins don't recommend disinfecting via UV light because the UV light won't help get rid of the virus itself from the particulate because it's pretty much held in your N95 mask. And even if you bang it, the static charge will keep that particulate. That will, the UV disinfection will help your mask work better. Ultimately, what's causing us to throw away masks is they're becoming soiled, wet, or dirty. So storing your N95 mask when not wearing it in a brown paper bag can help fix that. And then when you're folding it, usually they have a normal fold crease right in the middle. Go ahead and fold it. Go ahead and put it in your paper bag. If you don't have to fold it to put it in your paper bag, then you're good to go. Just put it in, fill it up. Go ahead and write your name maybe on the strap. I wouldn't recommend writing it on the actual N95, but this way it actually helps you with the preservation of your PPE and knowing it's your PPE. So now I want to go ahead and take the opportunity to take on some questions that people may have that may be separate or additional clarification on what has been discussed. And I believe Sean will help me with any of that as well. You can go ahead and type in the chat, or Sean can go ahead and help us.
Yeah, that's great. So nobody's chat. Thanks so much. That was great. Nobody's chatting to me that I see anything in the chat. I don't know if people are sending it to you privately. There's 1, 2 people are welcome to unmute themselves, undo their video, and ask a question live. While we're waiting for people, don't forget Ashley sent around a little bit of a link, a short bit.ly link in the chat. That's the link that you would put in your web browser to get to the online Excel form to fill out your info so you can get your CEUs. It's not typically a quiet crowd, so don't forget to unmute.
What is the latest on reinfection? Oh, was there a question? I think I may have.
Yeah, how does that, the question from, what is the latest on reinfection?
So right now we are waiting for additional information about antibodies overall. So we need additional serology data for that. So we're unsure what reinfection may be and what your immunity could be if you are infected. I would have to say what we have seen in some of our patient populations is maybe somebody comes in, they are infected, they are sick enough to need hospital admission, and then they get better during their time, they develop no symptoms, their symptoms go away, we discharge them, and then they come back and they are worse. This is a progressive disease ultimately, so we are seeing people who are sick, then their symptoms go away, and then they come back into the hospital with more severe symptoms. Unsure about any reinfection and any immunity. We're just waiting on additional evidence-based research for that.
So there are questions about medications, and I'll just answer in general, like remdesivir, right? They're right. The medical community, unbelievably, right, has really mobilized to get randomized trials up and running, right? Unbelievable IRBs to get these things going. So there are now dozens and dozens of structured randomized trials. So I don't think that we can really comment on things like remdesivir and other agents. Frankie, there was an article, people have seen articles in the past few days stating a new sign linked to COVID infection is a rash. Somebody else had talked about some red marks around their eyes from recall in the past. Are you hearing anything about rash or these rings around their eyes?
So this has been something that I've seen in a few of the media articles, so on and so forth, but we have not made a decision how this truly chimes in. We just need a better sample and more research out there to really pick this up. It seems like it will be a smaller portion of it, but ultimately what happens is when a more prominent symptom gets a lot of research behind it and more light, and for example, the decreased sense of smell and taste was a huge one that we have since added that into our algorithm for screening, and so did CDC as well. So once there's more research to back it, go ahead and move it on up into the appropriate symptoms to help you do some self-surveillance and self-check.
Great. Can you weigh in on the issue of folks using a CPAP machine while in proximity to other people? So I know one of the things that's come up for sure. So we know in the hospital that aerosolizing a CPAP or a patient, yeah, that's an incredibly high risk for a PUI or a COVID patient. What about other people at the station, right? So these guys are everyone's sleeping in quarters, right? And there are providers there with CPAP masks.
Mm-hmm.
Is there
So generally speaking for CPAP, we do know it's an aerosolizing procedure ultimately. When you are actually sick enough for hospitalization, we are worried about CPAP. So I would urge these people who are using CPAP machines to be very diligent about what their baseline are to go ahead and determine whether or not they're feeling well. They should be diligently monitoring themselves just to understand how they feel ultimately. And if an individual who does take a CPAP or does have a CPAP machine, then we would need to be weary about it. But generally speaking, if they are asymptomatic, pre-symptomatic in the beginning phases, they're not as infectious. So there's a lower risk ultimately in comparison to somebody who has lots and lots of symptoms who requires hospitalization.
How long after clearing up of symptoms does reinfection show up?
So we don't have a lot of data about reinfection ultimately. We just don't yet. Serology is something that we're getting more and more data on. We do have serology tests, but you may have the test itself, but the interpretation and how that data is used is the next step. And that's what we're really missing ultimately. Even though this virus has been occurring since November 2019, we are still behind the times of collecting solid data because, as we have known, this has been a roller coaster and has been quite different for every single country depending on their medical infrastructure.
And then is there a measurable difference in exposure risk of safety glasses versus true goggles versus face shield for eye protection?
Okay, so generally speaking, depending on the type of eye protection that you do have, some might be a full wraparound, some might be just a face shield, which means that you could see through here. It would be, as with any PPE that you're not familiar with, you need to take you need to take your time with it to make sure that you are using it to your full advantage. So for example, many of our healthcare workers will have a face shield, which means that you may get an exposure this way or this way. So it's about reorienting yourself during your patient care and patient assessment to make sure that if you were in front of the patient, if they were to sneeze or cough, it will just land on the shield. You're not putting your face up so that way it could go up there. You're taking your time if you're in an unfamiliar scene, just taking your time to ultimately use your PPE to the best advantage. Yes, no PPE is 100% perfect. Ultimately, we're about reducing the odds here. So making sure that if your PPE can be used effectively by not moving around and exposing any gaps that protect your mucous membranes, that is advisable.
There's been a lot of talk about not using a bag valve mask on AMBO calls. Is this just for PUIs or for every patient? How can we more safely treat patients if they need respiratory assist? I don't know if you can address that, or I'm happy to chime in.
So I know that sometimes these bag valve masks might have a filter that you can slide in, a viral filter of some type that can help reduce any sort of exhalation ultimately. So if there is an opportunity to procure that, that would be beneficial. I would have to dig into the research to give you some quantifiable numbers on the risk ultimately if you didn't have that viral filter in there, but it's not as aerosolizing of a procedure ultimately. What we do know is that this is a lower respiratory virus, so generally speaking, in your lower part of your lungs is the most infectious, so that way we're just worried about anything that could happen aerosolizing deep down in the lungs where a lot of the more potent virus could live, the higher concentration. But I'm curious if you have anything additional to add, Sean.
Yeah, I think that, that just we're certainly approaching anybody. You show up with somebody's respiratory distress, that is a PUI, right? I mean, we're very low threshold. At the hospital, all rapid responses and codes are PUIs by definition.
Correct.
So we are bagging patients as long as we have the protection on, right? So all the providers have to have the gowns, the masks, the gloves, the eye protection, the N95 mask prior to us being allowed to bag in a patient. Yeah, and then we try to move toward intubation as quickly as we can because, yeah, it's definitely a risky procedure, and yeah, providers need to have protection on.
Yes, and you definitely hit the nail on the head. Is when you approach this, if you can go ahead and have the appropriate PPE on, that is very beneficial. Ultimately, if you're in the appropriate PPE, having that viral filter and the bag valve mask, it essentially cancels out because you're protecting your mucous membrane.
There was a comment, how are healthcare providers getting sick? Were they not aware a patient had virus and didn't wear PPE, or were there breaches in PPE?
So this is always very interesting because you may see in hotspots like New York and Seattle and various other places overseas, globally, that there are healthcare workers that are contracting the virus. And what's not ever being mentioned is how they got infected. We know that the virus is circulating. We do know that they may have encountered it because of sick people coming into the hospital. My assumption can only be that maybe they weren't wearing the appropriate PPE, or there's not enough PPE anymore at their facility, which caused them to wear less PPE than what is recommended to protect yourself. So we may see that ultimately as the reason why some healthcare workers at Hopkins, we have not had a healthcare worker contract the virus while working on any of our COVID units. So if you do follow the appropriate PPE, you are effectively lowering your risk of contracting the virus.
And I think one of the biggest challenges when we're faced with an emergency is just to make sure that we pause and make sure you got your right? Because when you're seeing somebody in distress, my first reaction is to get to their side, right? But yeah, to be able to pause and just make sure that you have appropriate PPE is definitely a change in practice. Blood clotting is being associated with COVID infection. Should we be looking at stroke patients for possible PUIs?
So this is also new research that I just read about, and I believe it was today I read an article about it. So I have to dig into this a little bit more. Chances are, if you're going to have one symptom for COVID, you're going to have a few as well. So I think the general assumption is, because this is a pandemic, officially ruling out somebody as a PUI is primary for your safety, and then going ahead and triaging it. And if you are slightly unsure, I would just rest assured, practice the appropriate COVID PPE, airborne with eye protection, your gown and gloves, to make yourself feel better, and then ultimately transfer this person to a facility for a full assessment.
And I think you shared before, as more and more of these symptoms become clear and enough cases, then it will escalate, and we, following the guidance of the CDC, will include these types of things as we become more concerned about the consistencies of these symptoms, kind of as presenting signs and symptoms of a COVID patient. I know there have been some emails back and forth in the fire service community within the past couple of days that a lot of these patients are kind of thrombotic, right? They're definitely a subset of patients who are having clots. But these are mostly kind of in the hospital of complications of care, right? They develop pulmonary embolisms. These aren't patients who are just, walking down the street and all of a sudden have a huge pulmonary embolism from COVID, for example. So we're definitely addressing the hypercoagulable state more aggressively, but I don't think that impacts us as much in the pre-hospital setting, in my opinion. There's concern over supply of PPE as this goes on. Do you view the gowns as ancillary splash protection versus a higher protection device, i.e. N95?
I think I'm just going to need some additional clarification on this question. Is it more so what I view as best to keep people safe, an N95 versus a gown? I think ultimately you need to protect your respiratory tract, the respiratory virus. So the N95 and the eye protection are kind of at the tippy top. And then you do have your gowns and gloves ultimately. Once these infectious particles sort of land on surfaces, and as long as you're not picking them up and rubbing your mucous membranes, we're not worried about them, then they would be considered a low risk ultimately. There is more of a push for people to get creative, and there are other organizations making reusable gowns, so on and so forth. This is something that hospitals have now been exploring. Desperate times do call for desperate measures, and we're embracing creativity right now, but respiratory protection is absolutely priority, and then covering your eyes up, your mucous membranes, that's what you really do need. And I believe CDC guidance echoes that as well. I'll share the link to you, which has a nice table, sort of being like, if I have this but not this, this is my risk.
I've heard of patients having increased incidence of kidney failure and blood clots. Are these late signs or only rare events? I don't think they're rare. I think that they are a complication kind of amidst the care. I don't think that they're presenting signs. People don't show up with isolated kidney failure or blood clots, but they can have kidney failure, unfortunately, and they can have thrombotic complications for sure. Any thoughts on any chance of long-term issues with patients who have recovered from COVID? Have those who have recovered had elevated liver enzymes or kidney dysfunction or cardiac involvement return to baseline?
So that is very clinical, which is outside of my expertise. I will lean on you, Sean, to see if you can go ahead and...
Yeah, I think it's early. I think it's definitely early to figure out how long the rehab is for these patients. Patients who are prone to respiratory failure, getting paralysis, right? They could definitely have significant neuromuscular weakness that could happen for quite a while. Early on, there was a rash when patients were getting better. They would have this acute cardiomyopathy, and there were some deaths as a result of that. Yeah, but I don't know about I think we're too early for long-term kind of follow-up. The need for a gown is so great that people will actually use trash bags as ponchos.
Yes, we're seeing a lot of creativity embraced in places that are very resource poor right now. We have the strategic national stockpile being used in various parts, and the federal government is taking it on its shoulders to distribute that. In desperate times, there are desperate measures, and consulting your organization and your health system or your government system overall for guidance can help lead the way. Ultimately, some protection is better than no protection, though, I will say.
I think that's all I see. Feel free to unmute and ask if I missed your question, but I'm pretty sure we got through the list. Oh, here comes something. What is the incubation period until you are able to obtain a positive test? What are your thoughts on the value of antibody testing? Is fever a must-have symptom for testing or may have?
So generally speaking, I believe the information that I was reading before this said that probably the incubation period is, you know, about 1 to 14 days. Generally speaking, we're seeing about the 4 to 5 range. So if somebody were to get a RNA PCR test, which is the common test that they're using in testing right now at the state level and also through the hospitals and outpatient drive-throughs and stuff like that, they can detect it then. So when you are symptomatic, you will typically get it. So the incubation period would be about that 5-day range, which then you would show symptoms. Then you would go ahead and have a positive test. Sometimes you may hear of people who have symptoms, but their test may be negative, and it is a general thought from an infection prevention and control standpoint that there may be an inadequate specimen collection. So you're typically doing a nasopharyngeal swab, which is quite far back. People typically say you're tickling the brain. So if you're not going as far back to actually collect a good specimen, the test is only as good as the specimen, you could get an accurate result ultimately. So that's what we're seeing. A fever is not a must, it's just a part of it. There are some research studies that actually said prior to somebody getting a fever and a sore throat, they lost their sense of smell and taste prior to it. They've seen it sometimes in pregnant women in particular, that population has displayed that symptom before anything else. The virus can manifest differently, but you do not need a fever to have testing. And ultimately, you would like to get tested if you had an exposure, like a very extended contact time with somebody who's a laboratory confirmed test, or you are symptomatic. The test is of no use if you are not symptomatic. Typically, you're just waiting on it to incubate for you to actually show symptoms, or you have had a exposure to somebody with a lab confirmed, and it is within close contact. A family member or a very close staff member, corridor area would warrant that.
Frankie, while we're on that super fast, what are the thoughts about pregnancy and complications with pregnancy with corona?
So we have not seen a lot of vertical transmission from a positive mother to a baby. It's more infrequent right now. So generally speaking, because pregnant women are a special population that are highly vulnerable, a lot of women at the Hopkins hospitals are being ruled out if they are actively in labor. So we haven't seen many babies come out positive from positive mothers. So we're not seeing any vertical transmission. So once again, a special population that we need more research out there. But ultimately, in sort of this pediatric world, it seems like children are very resilient ultimately to this virus, and we can understand why, but they're more mild ultimately. Neonates is a special population, the newborn babies, but for pediatrics at large, we're not seeing a lot of complications.
And I read a cohort study for pregnant patients that there may be earlier labor, but there were no significant maternal nor fetal complications associated with COVID.
Okay,
What else we got? What is the, oh, got that one. Great. And then is it possible once someone has been infected and developed antibodies to get infected again?
So we don't really know just yet. So the antibody and the serology testing is very new to us. We have the testing capacity, but once we have the test, what do we do with it? What does it mean? So we're not sure about any sort of changes or the ability to become reinfected and then it will just be a mild version. We don't know, like once you have it, if there's some immunity, for how long. So there's a lot of universities right now that are collecting blood specimens from people that have been sick to try to determine what exactly is going on in the human body. So that's a critical, it's a big gap, it's an unknown for us.
Do you know what I heard from the immunology group? Did a small talk within the Hopkins community, and I learned something. One of the issues that they're having with antibody testing is what are they testing for, right? So they're finding, they're not sure that they're identifying people who have had some coronavirus in the past or the current coronavirus. So if they have an antibody test that's positive, but it's positive against a past coronavirus infection, then you're still at risk for this novel coronavirus versus making sure that the antibody test is identifying proteins generated by the current novel coronavirus. I found that really clear to understand, oh, that's why we don't know whether antibodies, if that works or not.
Good. Yes, there are some antibody tests that you may see and hear about being like China has an antibody test. There's a $15 one. So in general, coronavirus is a large family. There are 7 coronaviruses that are actually of concern. 3 of them are novel, ultimately. So you have your SARS, which happened in 2002. You have your MERS, which happened in 2009 and 2013. And then you have your SARS-CoV-2, your COVID, essentially. And these are the 3 novel coronaviruses, but the other 4 are just like very common cold, which ultimately make up the 7 big ones in the family. So yes, coronavirus, you may have heard it. That's why it's on any sort of Clorox bottles. It's actually very common. It can just cause a runny nose. So it lends itself into, we're not sure what the antibody test is picking up that you may hear is $15 from China or anything like that, because it needs to be very sensitive for those particular proteins.
Have we started testing using saliva yet? And what's the difference in sensitivity with testing using a saliva versus a swab?
So generally, our primary tests that we are using are, we did a nasopharyngeal, we've done oral pharyngeal, and then we've done bronchial lavage specimens. Sputum is more of a, we don't prefer it all that much. We prefer to do more of the NP and OP. I don't know that research to back it. I know that CDC initially pushed it out and that was sort of the best, and then we just developed testing around it, that rapid PCR testing. I would have to look into it ultimately, but for bronchial lavage, BALs and stuff like that, you're actually getting deep into the lungs versus when it comes to sort of any expectorated sputum saliva, you're only getting so far back ultimately. So it might not be a good specimen.
Do you see any value in achieving 2 negative tests after a positive, or is it better for the guidelines of 72-hour fever-free and 14 days since onset? So I guess this is getting back to work.
Yes, so generally speaking, defer to your workplace, and ultimately they may be quoting CDC guidance. If you were positive initially and now you are feeling better, if you do have a resolution of 72 hours of symptoms, that may be enough. I think you should still go ahead and monitor yourself as well, just because of what we've seen in the hospital where people are feeling better and don't require any hospitalization care, but then they are getting readmitted later. Ultimately, it may be they dip back in, but if you are not symptomatic, you're not as infectious. So 72 hours after resolution of symptoms, you're good to go. And that's what we have used as our benchmark in the hospital. So achieving the
Oh, sorry, go ahead.
Achieving the 2 negative tests after a positive, I think going by the symptoms ultimately will help us preserve a lot of the testing capacity that we have. Yes, we can test, but we are running low on reagents that we use to test because of a lot of the massive testing that we're doing, so on and so forth. And some people just want to know we're trying to preserve our capacity. So if you have a resolution of symptoms, practicing the best practices, hand hygiene, mask will contain your infectious secretions, physical distance, those layers will help also limit the spread as well, because we also don't know about reinfection.
Have you seen, do we think there's any correlation between individuals who have not had a flu vaccine becoming affected versus people who have been vaccinated?
No, there's no correlation between that. This is a completely different virus. It has completely unique receptors as well. The flu is in itself, the only similarity would be the respiratory virus ultimately, but we do not see any correlation ultimately backed up in evidence-based journals or anything.
Do you know anything about the theory of using ibuprofen or aspirin making someone more susceptible to catching COVID?
We use ibuprofen and Tylenol on the patients in the hospital, and they've been in the hospital and they're not passing away. So I think we can officially debunk that. It's very easy to get caught up in a lot of the sensationalist media about this. I should drink warm teas. I should gargle with this. So ultimately, ibuprofen, Tylenol, A-OK.
Do you have any opinion about the infection being actually more widespread, either undetected or misdiagnosed? That's coming into light now that maybe we had cases prior to the ones that were widely publicized?
So, I mean, this is interesting in general. It's a respiratory virus. We were in flu season, so you have a lot of influenza-like illness. We were still in the beginning phases of what we know about symptoms. There is a likelihood that it has been circulating and it was just a little bit more severe. It may have been in the US prior. As we know, there's a lot of global travel right now, and the disease is really only a flight away. And with a lot of practices and high-touch surfaces and people touching their face, so on and so forth, and that, I think there is a probability for it. Especially when we were really looking for these very narrow symptoms initially, being like, were you in China, in Hubei province, Wuhan city? Do you have a fever or shortness of breath and cough? And now it has expanded now where we're just like, we would like one symptom or an exposure and we're good to go.
Can you share a little bit of the difference really fast for folks, the difference between airborne and droplet? Like, so for example, you know, is this stuff as contagious as the measles?
So, yes. So this is not as contagious as the measles. The measles has a R0 or a reproductive factor of, I think it's 16 to 18. So it means that it can spread to that many people. And measles is primarily via an airborne transmission. So when I laugh, sing, I'm breathing, I'm exhaling like very tiny, tiny particles that will linger in the air. And ultimately, measles will go ahead and linger in the air for about an hour. I haven't thought about measles in a very long time, but I believe it's about an hour. And generally speaking, because it's lingering in the air, these very tiny aerosolized particles from your respiratory tract again, you can breathe them in. And it probably takes a very small number of these organisms to make you sick. So because it's lingering in the air and it's very hard for us to remove it from the air, it spreads quite easily. Versus droplet. Droplet is I need to sneeze, I need to cough, I need to do an aerosolizing procedure that's gonna like make larger droplets come up. So larger droplets are very heavy. So if I were to sneeze, cough, or anything like that, they're only going 6 feet because they're effectively falling very quickly. And generally speaking, these types of viruses that are respiratory are covered in fat, so they're covered in a lipid, and they're very easy to kill. And the risk ultimately for these is picking it up off a surface that somebody has sneezed or stuff like that, or sneezed in their hand. We see a lot of that, and when they touch a doorknob or they touch a high touch surface and then somebody else touches it and then rubs their eye because it's itching, or they pick their nose, so on and so forth. That's providing the opportunity. So I believe the reproductive factor for this COVID virus is about 2 to 3, and I believe flu is about 3 ultimately. So it's right in that range of the respiratory viruses. While we're measles, it's very hard for us to take out those particles that are laying aerosolized and floating in the air for up to an hour, unless we were to have a filter system, or there would be a lot of air exchanges. And then ambulance in particular, the air exchanges are typically 31 per hour. So that's a lot of air exchanging. So it's cleaning out all that air very frequently, minimizing your opportunities to take in anything that is from a patient or any aerosolizing procedures.
What are your thoughts about when the weather warms up? Is that going to have any impact on the infection? Does the weather have anything to do with it at all?
So generally speaking, there has been new research that says that the virus can start to degrade, so it becomes less pathogenic, less likely to cause disease. And it takes about 160 degrees to fully deactivate it. I'm waiting on more research to hear about that. But generally speaking, if we do have sick people that aren't practicing good practices, we're still going to see it circulate around. We saw that during the 1819 pandemic, where ultimately there was a third wave in a summer. So I don't believe that warm weather will truly affect it. What typically happens with respiratory viruses is it's not the crowding during winter or colder months that affects a disease to spread in a community. It's the humidity, because if I'm sneezing or coughing on a surface during the summer months, it will dry up more quickly and activate the virus. During colder months, the humidity is down. So if I were to sneeze or cough on a metal surface or a surface in general, it's going to lay there for quite a few days, more opportunities to pick it up. The flu actually circulates year around, so people still get the flu in the summer. And if we look at other warmer countries like Singapore and stuff like that, they're still seeing the virus circulate. And typically they're above like 80 degrees.
Great. That's about all I see for questions. I guess just one last thought, or one, any parting words for kind of, I think that there's definitely some providers who are a little afraid to come to work, right? They're afraid of, the risk of this, bringing it home to their families. Any kind of reassuring words? I mean,
absolutely. So just because this is a novel event, we don't need novel practices. It just means we need to take our time now approaching it much more. So when you're actually going to do something, the accountability now is very individual. My accountability to not touch a surface and touch my face, or think about what I'm doing more often, about like, how am I washing my hands? Am I getting up to my wrist? What have I been doing? Did I wash my hands before I eat? The accountability is a lot higher because it's now more prevalent. It's now, instead of just international, it is now in our front yard. It is here with us, and there is no end in sight. It is up to us individually to prevent the spread, because it is a contagious communicable disease. And I think that accountability is very worrisome. So it shakes somebody at their core when there's a new accountability.
And I think you did a really great job of talking about, the things that we should be incorporating into our daily habits right now, right? So when things happen, to pause, make sure that we have the appropriate PPE, always, right? Just make sure that you're wearing that stuff. Don't get I was at a code today, and we've been at this for 6 weeks now. And a provider, just out of empathy, right, approached a patient within 6 feet, but wasn't wearing any PPE. It's like, wait, we don't even know what's going on with this patient yet. Let's figure this out. But before you step into 6 feet, make sure you have your PPE. So there's that pause. There are things that we do at the station, right? The high touch cleaning you talked about, really making sure that we get that down. Social distancing at the station, right? Wearing our masks, right? Wearing our masks at the station, and whenever we're out
The levels of protection.
Right? And the social distancing, right? So instead of gathering around a dinner table, right, we need to do a better job of that. We need to stagger. We need to make sure that we're keeping our distance as much as we possibly can.
Absolutely. And it definitely feels weird. It's absolutely necessary to wear a mask even when you're in it. If I was wearing a mask right now, it's not a substitute for physical distance because I need an additional layer of protection. So when you can, to save any of your medical grade PPE, your surgical mask or procedure mask, I would recommend getting a cloth mask to a certain degree. They are uncomfortable. I very much understand that. I'm in one quite often when I'm working at the hospital or going out now to the grocery store, which requires one. But I think that it helps us ultimately all feel a little better. I know that as a healthcare professional, when I tell people what I do, they're more uncomfortable around me. So I wear it even to help people around me feel better because it protects them from me.
So somebody said,
could
how
this be
necessary and preventative is it wearing a mask in the station? So yes, the universal masking is something we should be doing. Yes.
It's just one layer of it, and it helps people feel more at ease. There's an additional question of could this possibly become a seasonal virus? So at this point, we're looking back at some research from the 1819 flu where people relaxed rules a little bit and they started opening up businesses and they saw another surge. Ultimately, some people forgot about these best practices and wanted to go back to normal life, their routine. So it became seasonal for 3 waves. This may become seasonal ultimately, because as long as we have little pockets of it sort of being passed around across the globe, there's opportunities for it to surge back up. And measles is an example of this as well, that we have a few outbreaks across the world that it's only one flight away, which is why we have a problem in the US with measles. Not as contagious, but once again, still a communicable disease that people sort of pushed away out of their sight.
Somebody said at some point when you wear a mask all the time, you get to take it for granted and start to discard the safer practices of not touching your face. Yeah, it takes vigilance for sure.
It does take vigilance. It really does. When you're wearing a mask, if you're alone or in your own quarter or stuff like that, you don't need a mask. If you're in your own car, that's fine. A mask is advisable when you are with in a group. You don't need to wear them at home. You're sort of at that area where a close contact may be exposed. It's a little bit different when you're at work. You have a much bigger space to go ahead and spread out if needed, but generally the mask is recommended ultimately to contain your infectious secretions, and then making sure you do hand hygiene before you touch it, or washing your mask daily if needed. So having 2 cloth masks to alternate can help when you are not actually in need of that medical grade PPE on the trucks.
Yeah, and I think this is a great opportunity to help coach each other, right? And to remind each other, right? So this isn't natural for us. So just today, as I was leaving the hospital and I was giving a report, providers were coming close to me to get that handoff, right? And I was like, wait, right? I'm stepping away. I'm taking a step back and they're taking a step forward towards me, right? It's like, wait, I just keep my distance, or, don't forget your mask, or, I reminded someone, stop touching your face, right? I'm watching them on Zoom and they're just touching their face constantly. And I'm like texting them, like, stop touching your face. Anyway.
Yeah, and coming up with like a keyword or something like that to even just like say, so that way you're not just like stop touching your face. A keyword can also help as well, so that way people know. And it could be a very fun word as well, such as pinata or fiesta. Anything you want, you can just make it a little bit fun. That is a low-key way to be like pinata, and people will stop touching their face. And this is only to advocate on their safety. And this is what we really need at a time like this. We've never been through a pandemic, and we're all in it together.
I completely agree with you. And I think, we just have to trust in our PPE and each other, right? We have to rally. I think we have unbelievable resilience when it comes to this, and I think that we have to support each other, trust our leadership. I think, I trust Hopkins. I think that you guys have our best interests at heart for sure. And I see what comes out in the fire department, and what the leadership in the fire department is doing very much echoes and mimics and is in parallel to the recommendations that I get at Hopkins, for example. Even things like, I remember when we gave out bags, people were like, are you kidding me, right? What a joke, right? People are giving us bags to put our N95s in, and I go to the hospital, and what do I have? I get a bag, right? I'm getting the same thing. Yep. Because that's what the evidence suggests, right? We're very lucky that we have unbelievably strong recommendations through the CDC, other professional societies, and yeah, we're very fortunate. And yeah, I feel safe if we can abide by this.
Absolutely. Any talk on a second wave this fall? So in general, what we've learned from the 1819 flu is when certain states have relaxed their rules, what would happen is the virus takes about 14 days to incubate. So that's 2-week time. Then the next 2 weeks, you see sort of an increase. And then ultimately, you're going to probably see another one because that person infected another one. So you're looking at 6 to 8 weeks of a new increase ultimately. And because we live in a transient population, who's to say that those people won't travel elsewhere across the United States, putting others at risk? So there may be a second wave ultimately if we can't get a flattened curve totally, and if there's no way to control the migration of a population or community, the movement of them.
Frankie, again, thank you so much for your time. I think that we've gotten through the questions. We've been at this for an hour and a half. So thank you so much for sticking out with us and yeah, sharing your expertise for caring for us and taking care of us.
All right, thanks y'all. And I'm more than happy to do a second session if needed, especially as this continues to wage on. More information will come out around any sort of blood clots, bruising, so on and so forth. So to help you sleep a little bit better at night, I'm happy to give you the resources.
Thank you. Have a great night. Be well. Stay safe.
Bye.